Second speaker will be Dr. Ahmed Darwish. Dr. Ahmed Darwish is assistant professor in Mansoura University. He is going to present a very interesting issue which is called the blood banking Mansoura University experience.
Thanks a lot, Dr. Amal, for your invitation. Today, I'm going to speak about cord blood banking and our experience in Mansoura University. And thanks, Dr. Khalid, for paving the road very easy for me, because he told us everything about the donor issues. But I'm going to speak about cord blood banking in more details. First of all, I have to highlight that the hematopoietic stem cells, as Dr. Khalid has said, that it is the option, or we can say that hematopoietic stem cell is standard of care for a lot of patients, especially cancers, immunodeficiency, and some benign hematological disorders, even some inherited disorders as well. Of course, we have thalassemia being one of these issues, but of course, cancer is one of, we can say, the most common indication for hematopoietic stem cell transplantation in pediatrics. It was Edward Donald Thomas who was done the first successful engraftment. It was in 1957, and then the hematopoietic stem cell transplantation was only referred to those who are matched-related donor as a standard of care, as Dr. Khalid have said. But the problem is that it is difficult to find this suitable donor. If you have a monozygotic twin, it will be an option of 100%. But if there is no monozygotic twin, so the option will be only 30% because of the presence of siblings. It may rise up to 40% in our community because of the large family members. But if there is no related sibling, so we have to reach for other related non-siblings, and this option will be only 5 out of 1,000. The first syngeneic hematopoietic stem cell transplantation, which means twins, it was in 1969. And the first matched unrelated donation for transplantation was in 1973. And it was just luckily because there was a stem cell, unrelated stem cell present in Denmark blood bank, and it was given for a patient. And the problem is that whenever we want to search for a certain donor, it looks like that we are going to search over a wide scale, but and this will take time and this will take money while searching for. Therefore, we have to get a registry, as Dr. Khalid had said, and the first registry was found in 1974. Thanks for this gentle lady. She was the mother of a child called Anthony Nolan. Anthony Nolan, he is a child having Wiskott-Aldrich syndrome, and he died at the age of 3 years because of absence of donor. And she decided that when she found that in 1973 a successful matched unrelated donor, so she started the first registry in 1974 in United Kingdom, and it's working up till now. This was followed by what we all know for the National Marrow Donor Program in New York, in USA, and it's working till now. And as Dr. Khalid said, only it is presented mainly for Caucasians, and other minorities are not presented as much as the Caucasians are. Another one, which is the International Registry for Donors in Netherlands, it was also organized in 1988 in Europe. Then this was followed by the issue that whenever you want a hematopoietic stem cell donor, so you have two options. One of them is the matched related and the other is the matched unrelated donor. But the problem, as Dr. Khalid said, that 30% is an only option for the matched related, and we have what we call the ethnic minority, which are not presented well in the registries worldwide, so we are not presented. Thanks for this also, French lady, she is a pediatrician, pediatric hematologist. She was the first transplanter for cord blood transplantation. It was 1988 for a patient with Fanconi anemia. He was at the age of 4 years old, and he was transplanted from the cord blood unit of his sister, and this was published in the New England Journal of Medicine. And the first public cord blood bank was just organized in 1993 by Paul Ruppenstein, this American scientist, and starting since this age, they started what we call the banks worldwide, the cord blood banks worldwide. It was built in Paris, in Germany, and in Milan, and in other countries. And also Würzburg in 1996, she started what we call the unrelated mismatched cord blood, and this was a breakthrough because the first cord blood transplantation was a related matched donor, but this is an unrelated and mismatched donation. Because of this wide issue of cord blood transplantation worldwide, so they started to register every cord blood transplantation in what they call Eurocord, and this is located in St. Louis Hospital in Paris. And thanks also for Balin Karen, or Karen, this Karen Balin, she was the first hematologist to do the double cord blood transplantation for adults, and this is only 12 years ago. After then, they started a lot of issues of cord blood transplantation regarding cancer as leukemia, thalassemia, metabolic diseases like immune deficiency and immune deficiency. And this by chart can tell us the spectrum of cord blood transplantation, especially 50% of these issues are regarding acute lymphoblastic and acute myeloid leukemia, and of course, secondly, is aplastic anemia. Dr. Khalid have mentioned some advantages of the cord blood. Of course, it's something which is biologically unnecessary and it will be discarded. Secondly, it is a harmless collection, it's ready to be used, and it is an issue of high expansion whenever we want to do some sort of expansion for the hematopoietic stem cells in vitro. And of course, the most important benefit is the reduced graft versus host disease and a permissible mismatch, 1 or 2 mismatch. And also it has been highlighted in the previous lecture that whenever I want to go to the registry to search for a volunteer, it may take time, reaching up to 4 months. This may take time. This is not good for the patients. But if we go to a cord blood unit, it can take less than 1 month to search for. Cord is not a source of blood only, but it is a source of what we call the Wharton's jelly. It's a source of mesenchymal stem cells. And these mesenchymal stem cells, we have to pay attention for because it could be a source for treating a lot of diseases. All of them are right now clinical trials regarding regenerative medicine. And if we go for regenerative medicine, we can see that neurologists, endocrinologists, cardiologists can get benefit of these mesenchymal stem cells from the cord tissue. And I have to highlight something very important here. In the last paragraph, it is said that the mesenchymal stem cells from the blood of the cord have greater proliferation potential and longer telomeres when are compared with other sources of mesenchymal stem cells. Secondly, we have to mention also that we have some challenges regarding this issue because, number one, the trial endpoints are not clear enough. Number two, it have got some irregularities to be prepared before. And thirdly, if we just encourage banking of blood for personal use, this will affect the public donation. Public donation, of course, means that we have to donate blood to the banks, but private banks means that I have to save it for myself. And there is a third issue, which is called the hybrid, which means that half of the unit goes for public and half of it goes for private. But the American Academy of Pediatrics said that it's not recommended to save it privately. It's better to be kept public. And as Dr. Khalid said that nowadays we have a registry mentioning above more than 770,000 units worldwide ready to be used and about 35 million donors. But unfortunately, as you can see, and as mentioned before also, we don't have units in Africa, we don't have units in Middle East. And we have to go directly for banking. We have 6 main steps for banking. The first of them is the cord clamping, and we will mention. And number 2, it will be the collection of cord disc after taking a consent, and then transferring the unit safely under optimum temperature, and then processing reduction of the volume, and finally storage. This, how can we prepare our bag? The bag is consisting of about, it's containing about 20 ml plus or minus, or plus 10 other ml of CPD, which is an anticoagulant. We have to make it ready before the process, and we have two main methods to collect the blood, either to collect the blood directly from the cord while the placenta is still intrauterine, or we take the cord blood while the placenta is outside. We call it ex utero collection. We just like give the cord nearer to the baby, and then we just to do what we call sterilization using alcohol and betadine, and leave the blood to go directly by gravity through this bag, and then we just transfer in an ice box with a temperature control. Then we have to take some samples from the mother to do some virological screen for the maternal blood and for weighing the cord blood unit to collect the volume. And then, because we cannot keep a unit less than 70 ml of cord blood, and then we have to do the process of processing, or we call it volume reduction. All times ago, they used what we call hydroxyethyl starch. It will be added under the biological safety cabinet to do some sort of RBCs reduction or RBCs precipitation. Then we connect the cord blood bag to another bag, another 3 bags, in order to do a process of what we call centrifugation. This centrifugation is done into 2 steps. The first step that we just isolate, as you can see here, we isolate it into the plasma and the buffy coat and the backed RBCs. Another centrifugation will be done after the first transfusion, because we have to remove the plasma and the buffy coat in another bag. Then we do another centrifugation to keep the plasma and buffy coat. This can be separated using the ordinary manual plasma extractor. And this is a process which finally ends by collecting the buffy coat, which is including the stem cells. As we can see here, after this process, we have the backed RBCs, the plasma, it's not clear enough, and we have here the stem cells, which we call this is our target, this is the cord blood unit finally, which we have to preserve. But thanks for this automated technique, which we call it CBUX, it is an automated way to separate it using this technique, or using this kit. This kit is called the CBUX stem kit. And the CBUX stem kit works in this, I'll try to show this video. If you just look to this machine, it's working in a very optimum way, where we put a cylinder inside the machine. This cylinder, and here we have some sensors for the cells. And this is a bag for the cord or the stem cells, and this is a bag for plasma. And this is the cord blood bag collected. Then what will happen is the blood will go directly to the cylinder. And by this plunger, it will push the blood upward and doing some sort of centrifugation. Not like the previous one. The previous one is a top and bottom technique, but this depends on 3 cylinders, where the plasma goes first, being the least density. Then it pushes the stem cells. This is a mononuclear stem cells. And finally, it pushes back the backed RBCs to the original bag. And now we have 3 clear. If you can just compare this with the previous one, here the plasma is completely clear, which can tell you that the count of the mononuclear stem cells will be better, and this can give us a better cell dose. Another technique is called the AXB. An AXP system, but it uses a cooling centrifuge as well. It looks like the CBUX. Then, and it also works in the same way. It's a top and bottom technique. And finally, this is our target, this bag, which is the 25 ml mononuclear stem cell. After collecting this unit, we have to add a cryopreservative called dimethyl sulfoxide. It's added through a machine called a syringe pump, and this syringe pump we have to put the bag in an ice, because this DMSO is going to generate heat, and we just do it under the safety cabinet. Thanks for this cool mix. This cool mix is doing this mixing and at the same time cooling. And lastly, we have another new machine. It's called the Smart Mix, which can do both cooling and thawing. Therefore, we can also do 2 units. We can just do the 2 units at the same time. Finally, this is our target. This bag is 25 ml, and we have to seal it into 3 segments, and we have to wrap it, put it in a wrap, and remove the air from inside, and put it in a canister. It's aluminum canister. Then we put it in a controlled rate freezer to decrease its temperature from room temperature up to -100. And finally, we have to put it in the cryo storage system under -196. Elian Gluckman said that the minimum total nucleated cell count in a cord blood bag should be at least 3.7 multiplied by 10 to the power of 7. But Wagner said that it's a matter of CD34 positive cells. It should be at least 1.7 multiplied by 10 to the power of 5. For children, we are lucky because 1 unit can save a child less than 20 kilograms. But for adults, they need 2 or more. The challenges for cord blood bankings are, number 1, having a license, which is costly. Number 2, they found that out of 10 units, only 1 unit is used, and this adds for costs. Number 3, obstetrician said that delayed cord clamping should be at least for 30 seconds, and this can decrease the volume. So we have to select the units in an optimum way. Number 2, we have to select units which have got higher quantity of total nucleated cells. We have to use automated ways. Number 3, we have to search for new ways to have funds. And lastly, we have to pave the road for thawing the units by dilution, not by washing. Dr. Khalid said that cord blood units or cord blood transplantation have a disadvantage of delayed engraftment and, of course, the cost and issue of relapse. Nowadays, they are having clinical trials for new techniques to improve the immune reconstitution, especially by using the mesenchymal stem cells, which can improve the neutrophil engraftment made up to 13 or 14 days even. Okay, thanks for Professor Dr. Farha. She's a leader for cord blood banking in Egypt, I think, because she is a leader for having the first public cord blood bank. It's an STDF project. Also, we have 4 units in this bank. These 4 units are the stem cell biology unit, the regenerative medicine unit, the cord blood bank, and the molecular biology. Inside our unit, what we are doing is that we have to do some awareness for the mothers, to tell them what we are doing. So we give them some lectures in Arabic, and also we have to take consent from them, written consent, and then we have to collect blood, okay? Then, after collecting the unit from the university hospital, maternity hospital, we go for our unit to do a cell enumeration by the hematology analyzer for the total nucleated cell count and by flow cytometry for the CD34 positive cells. And we use the CPUX machine. And nowadays we just shifted to the children's hospital having GMP rooms with positive pressure and HEPA filters nowadays in our processing rooms. Also, we have the controlled rate freezer, we have the smart mix right now, and we have the cryo storage system. For molecular typing, we have the Luminex for doing HLA, and we have done about 28 units. 28 of the units are nowadays ready for transplantation, having their HLA, using even the NGS, because we have some, we can say that union with the Clinilab, and they are doing the 28 samples of the cord blood units, so they are ready nowadays. We have also another lab for the tissue culture. We have some posters in Arabic for mothers to tell them the benefits of donating of the cord blood. And we have another grant. It was a fund. It was 900,000 for selecting donor. It's a research have done, and we have just proved that collecting in utero is better than ex utero, because ex utero will lead to coagulation of the units, and we just are ready in the cesarean section, so they are better to be collected during cesarean section than vaginal delivery. And we discovered that males are better, maybe because of they are bigger in size, and whenever the neonatal birth weight is bigger, it's better to be given. So heavier babies, larger placentas, longer cords, and older gestational age are better to select units. These are our publications regarding the optimal collection. Even we just collect units from preeclamptic mothers. We do some issues regarding regenerative medicine, as using mesenchymal stem cells from Wharton's jelly for rat models for renal ischemia. Also, we have some research regarding using mesenchymal stem cells to be differentiated into dopamine-producing cells, and for mesenchymal stem cells to neurons for treating Alzheimer. All these are used not in a clinical way, but in experimental way. Also, we have isolate pancreatic endocrinal cells, or differentiated into pancreatic endocrinal cells in experimental way, and we have some other research regarding maternal neonatal predictive values. Of course, we have a lot of poster presentations like neonatal and ovarian failure, using mesenchymal stem cells on ovarian failure. This is Eliane Gluckman. And finally, we have just this poster presentation in last EBMT. It was for the CFU, the colony forming unit of the cord blood units. Ongoing research nowadays, we have the isolation and differentiation of mesenchymal stem cells from Wharton's jelly into hepatocytes. And we have comparison of autophagy mechanism in cancer cell line and mesenchymal stem cells from the cord, and the effect of autologous adipose-derived stem cells combined with carbon dioxide in atrophic scars for dermatology. And in vitro expansion, this is very promising, in vitro expansion of hematopoietic stem cells from umbilical cord blood. We have others, but we have to go directly for the funds. We have 3 new funds, not regarding the cord blood banking, but use of the mesenchymal stem cells in some gynecological issues. So these are our statistics right now. We have about 116 units ready for research, and about 49 ready for transplant. 28 of them are HLA typed. We have other samples ready for research, like plasma samples and serum. All of them are collected by a CPUX way. Of course, we have done a lot of workshops regarding cord blood banking and regenerative medicine, and even some educational courses, and manipulating some teaching for undergraduate as regard training of them, as regard issues of collecting and processing of the units, even from, and we have 4 conferences in Mansoura, and we have some national, international cooperations, for example, with the Galat Military Hospital. We have also an agreement with the Paris hospitals for training of juniors for immunology and histocompatibility and the cord blood banking, and even for bone marrow transplantation for 3 years, for a coming 3 years. Our next steps is going directly to have, number 1, this bioarchive, because it can keep about 3,600 units and make us able to do some sort of private banking, which can help us in a fund. And lastly here, we have the next steps that we have to pave the road for the transplantation in the oncology center and in the children's hospital, which we are starting right now. And of course, we have to accreditate, so we are thinking of about 500 units in order to be accredited worldwide. And thanks for our team, I have to mention them: Professor Dr. Farha, Dr. Sarah, she's an obstetrician. We have Dr. Ziad Tawheed, Dr. Muhammad Darwish for the clinical immunology, Dr. Mervet, Dr. Ashraf, and Dr. Sharif from the molecular unit, Dr. Adina, Dr. Sarah, Dr. Ayman, and Dr. Inji. All of them are sharing us in this issue, and thank you.
Thank you very much, Dr. Ahmed, and really congratulations for this great success in cord blood banking and cord blood preparation. But I would like to ask you, do you actually use this cord blood banking in transplantation? Not yet, not yet. Only you did. I'm sorry that I started the question.
هو
But this is a hot question.
هو ده اللي انا نهيت بيه البرزنتيشن، ان احنا عشان الوحدات دي تستخدم الترانسبلانترز لازم يكونوا اوير باللي احنا بنعمله، ده رقم واحد. رقم اتنين هيبقى في كوميونيكيشن، لان انا عندي يونتس فيها اتش ال اي. المفروض زي ما دكتور خالد اتفضل وقال انه عشان انا ادور في ريجستري لازم انا ككور بلاد بانك اكون اكريديتد، فيعترف بي عالميا. عشان ابقى اكريديتد وحضرتك تقدري تدوري لازم 500، لازم يبقى عندي 500. فهو رقم
You can be accredited in Egypt to start with Egypt.
ما هو ده اللي هيحصل. ما هو احنا لو على مستوى ناشونال طبعا يعني ممكن هنا في القصر العيني، ممكن في عين شمس، ممكن في 57.
Are you aware of this?
دكتور الشنشوري عارف كده كويس، وكان اتصل بينا في حاله.
And already
طب وهي الحاله فعلا كلمتنا وجاب لنا الاتش ال اي بتاعها، بس احنا حاولنا ندور ما لقيناش شبهه يعني، لان احنا برضو هم 28 حاله الاتش ال اي. طيب
Okay, thank you very much.